Mpox has again started ravaging nations worldwide in 2022. The WHO declared Mpox a public health emergency as it surges through Central Africa, especially outwards from the Democratic Republic of Congo, where clade 1b is endemic, and numerous Asian nations, indicating cross-border spillover. Welcome to our presentation on Mpox and its recent treatment strategies. Mpox is a zoonosis transmitted through respiratory droplets, through getting bitten or scratched, or via touching the animal's blood, flesh, body fluids, or skin lesions. Mpox can also spread among humans by saliva, by body fluids or shared items contaminated by them, by sexual contact, especially between men, also known as MSM, and by maternal fetal transmission during breastfeeding and childbirth. Who's most susceptible to Mpox? Infants, their immune systems aren't fully developed. Children, most have not been vaccinated. Men, especially those having sex with men, those who had STIs before or are having HIV currently, pregnant women, and residents or visitors in endemic places like Central Africa. Most victims experience fever, headache, tiredness, and lymphadenopathy in the first 2 weeks. Seems harmless, but leave it untreated. Various systemic disorders, including skin rashes, GI disorders, cardiac and respiratory complications, ocular impairments, and renal damage can arise. Currently, an infected person infects, on average, 2.44 susceptible persons. In March 2025, WHO reported over 3,000 persons infected among almost 140,000 cases as of April 2025. Moreover, peaking at about 10% in case fatalities as of March 2025, Mpox has claimed over 300 lives. To reduce patients' suffering and maintain workforce performance, novel therapeutic strategies have been researched to control the spread of Mpox. This includes murine studies concerning tecovirimat, cidofovir, brincidofovir, and plitidepsin.
One study on Mpox antiviral efficacy focused on TCV, BCV, and CDV. In vitro testing, 50 PFU per milliliters of 3 Mpox clade 1b isolates were treated with tecovirimat, cidofovir, and brincidofovir respectively in different concentrations. The cells were then incubated and plaques counted, which found similarly macromolar potency in tecovirimat, brincidofovir, and cidofovir. To test antiviral activity in vivo, cast AIJ mice were intranasally inoculated with Mpox, then treated with tecovirimat and brincidofovir through oral gavage and cidofovir through intraperitoneal injection. A routine exam was conducted daily, as well as necropsy at 7 DPI, which is days post-infection. Mice that survived 2 weeks after the treatment underwent terminal bleeding, and ELISA-based serological testing was conducted. The results showed that rats treated with tecovirimat and cidofovir had 100% survival rates, while brincidofovir yielded 80% survival rate. Additionally, treated mice demonstrated therapy-related reduction in weight loss due to Mpox clade 1b. Moreover, the infectious viral titers and viral DNA test results indicate that all 3 drugs reduce replication of Mpox clade 1b in the brain, lungs, and nasal turbinate of the mice, and a promised dual therapy applicability. However, this treatment strategy is limited by drawbacks such as the possibility of Mpox drug resistance and the reality of the late treatment for Mpox patients.
Let's move on to plitidepsin, which promises reduced risk of antiviral resistance. In vitro cultures underwent PFU determination and MTT viability assay, which found nanomolar potency but high toxicity risk at small concentrations. mRNA quantification in time addition testing suggested post-entry stage inhibition of Mpox replication. Western blotting on protein extracts found significantly reduced E3 and host EF1A, drivers of Mpox pathogenesis. In the follow-up treatment placebo murine study, mice were intranasally infected with Mpox on day 1 and received subcutaneous plideptidepsin or placebo on day 1 to 3 with healthy PBS. Control for reference. The mice were monitored for 11 days, euthanizing those with severe weight loss or clinical issues. On day 4, 7, and 11, mice were euthanized for lung tissue sampling, microscopical evaluations of inflammation, necrotic damage, and hemorrhages to yield histopathology scores. Real-time qPCR to analyze pro-inflammatory cytokine expression, and plaque assay to analyze viral loads were performed. Notably, viral loads, lung inflammation scores, and cytokine coding RNA profiles were all the lowest on day 4, highest on day 7, and low again on day 11, though higher than on day 4, indicating data concordance. Overall, plidepidepsin effectively suppresses viral replication and reduces lung-damaging inflammation. However, high toxicity risk, short half-life, and limited efficacy, possibly from post-infection injection, must be addressed when translating into human trials.
Of the treatment limitations we noted, we found deep interest in limited plidepsin antiviral efficacy, which Alberisio et al. Attributed to post-infection treatment initiation. In vitro evidence noted low Mpox viral loads when plidepsin was added before Mpox inoculation, rather than during or after Mpox inoculation. Therefore, we propose prophylactic plidepsin application. This outcome is consistent with another study, where a group of mice received continued daily dosing of plitidepsin for 2 days. Similarly, a significant 99% reduction in SARS-CoV-2 viral titers in murine lung tissues relative to controls further supports viral load reduction with early plitidepsin addition. This phenomenon is mechanistically justified. Plitidepsin disrupts translation of mRNAs like the COVID-19 nRNA, limiting production of viral structures and accessory proteins. This occurs by targeting EF1A, which reduction is also correlated with reduced Mpox virulence factors. Furthermore, despite having a short half-life, Mpox viral loads, PFU, remain suppressed on day 4, a day after the last dose, meaning plitidepsin provides sufficiently long antiviral protection. However, plitidepsin should be strictly reserved for high-risk individuals, to prevent risk of antiviral resistance induced by selective pressure stemming from the overuse of drugs.
Overall, Mpox clade 1b, reporting high incidence and fatalities, causes widespread systemic damage. Murine studies involving therapeutics like tecovirimat, brincidofovir, cidofovir, and plitidepsin promise effective inhibition of Mpox replication, lung protection, and enhanced Mpox immunity. Interestingly, for plitidepsin, prophylactic use promises enhanced antiviral protection. That is all, and thank you for listening.